Hi everyone, I'm Amanda. I'm a Galley Healthy Ambassador and I'm really excited to be here today to do an Instagram Stories takeover on IBD and fertility and family planning. So I wanted to start by just sharing a little bit about my story and then I'll jump right into the questions that I got from all of you. So first of all, I wanted to thank you so much for responding to the questions and the polls that Galley posted this past week. It really helped me to know what you guys are looking to hear and to answer some of the questions that you guys submitted. So a little bit about me. I have Crohn's disease, and when my husband and I started dating several years ago, we talked about how we really wanted to become parents. We knew that with my medical history and the medications I was on, that might look like one of several things to us. We were open to surrogacy and adoption, but I also knew that if there was any opportunity for me to carry a baby, I really wanted to do everything possible to try. So when we were ready to have the discussion about starting a family, we went a couple different routes. I started by speaking with my gastroenterologist. We talked about my current health history and where I was at, what medications I was on, and in what state my Crohn's disease was in. Next, we decided that in addition to speaking to my regular OBGYN, who I'd only been seeing for a short while, that we wanted to get some input from some specialists. So my husband and I sat down with two different maternal fetal medicine physicians, or MFM is how they're referred to. And those were quite lengthy and quite detailed appointments. We went through all of my diagnostic history, the medications that I had previously been on, the medications that I was currently on, and what our goals were for family planning. And both doctors said the same thing, that the medications that I was on, which at the time and still to this day include Remicade and azathioprine for IBD. I also take medication for depression and anxiety. And I was told that given my situation and my health history, those medications were generally approved for pregnancy. Now granted, every single case is different, and if you're considering pregnancy or trying to get pregnant, I always recommend talking to your provider about your specific medications and your body and your health. The next piece of information we were told from both physicians was that remission was key. Both physicians really wanted to see that I had been in remission for about 3 to 6 months before we started trying to get pregnant. And honestly, that was kind of a tough pill to swallow because when I went to that appointment, I wasn't yet in remission. My Crohn's disease was managed. It was better managed than it had been in a long time, but it was not in remission. At that point, we really took it upon ourselves to focus on managing my Crohn's disease as best as possible to get to that remissive state. We tinkered with my Remicade dosage a little bit in the frequency in which I got it, and made a couple of other small changes, but some of it was also just patience and time. When my GI doctor felt confident about the state of my Crohn's disease, she kind of gave us the nod of approval to begin trying to have a family, and we kind of left off from that point. Everything I had been told and everything I had read before then told me that my IBD should not impact my ability to get pregnant, but that didn't mean that other things weren't impacting my ability to get pregnant. And when we started trying to have a baby, I sort of thought it would just happen, that, you know, I'd do some ovulation testing and we'd have timed intercourse and we'd make a baby. About 10 months into that plan, I was starting to feel frustrated and discouraged. Every month, another negative pregnancy test in my period, and another month of emotion and disappointment, and trying to understand what was happening, what was going wrong, how I could do better, how I could fix it. And honestly, the hardest thing that I learned about going through infertility is that you can't really do anything. It's not your fault. You didn't cause it. And a lot of it is honestly out of your hands in terms of trying to fix it. And so I went to my OB at that point and said, hey, my cycle length has been varying between 32 and 39 days. And I just wanted to know if there's anything else I can do to help us get pregnant, anything else I can do to like regulate my cycle or time intercourse better or any of those things. And she had me do some testing, and she also recommended that my husband get a sperm analysis. That insight from her was really helpful, and we learned a lot of information, including the day that she called me and said, well, I hate to break it to you, but I don't think you're going to be able to get pregnant without technological intervention. So that was not what I had been expecting to hear. That was kind of a knock the wind out of you moment. We went on to find out that my husband's sperm analysis, while not poor, was not quite within normal limits. And I almost had that moment as like someone who's been an IBD patient for a long time now, like, oh, maybe it's his fault. Like maybe his healthy body is doing something that is not allowing him to have enough sperm, quality sperm, mobile sperm, etc. And that was almost a relief on my part that like maybe it wasn't my fault. We went on to schedule an appointment with a reproductive endocrinologist, or an RE, who handles infertility treatment. And of course, in the way that the medical world works, we had to wait several months to get in to be seen for that appointment. We went through some additional testing, and my husband went through another analysis, which this time came back fairly normal, better than his first one had. And we were ultimately diagnosed with unexplained infertility, which means that there was no like medical reason why we hadn't yet been able to conceive naturally on our own. This was both a relief to me and really frustrating. It was a relief that nothing was inherently wrong, that I didn't need surgery or any sort of invasive procedures to fix something, but it also meant that there was no way to pinpoint exactly what was causing us or preventing us from becoming pregnant. Our doctor recommended that we start with something called IUI, or intrauterine insemination, which is a very non-invasive method of fertility treatment. Basically, in layman's terms, my husband provided a semen sample, and on the day before I was going to ovulate, I received an injection to make sure ovulation was timed, and then I went into the office and they injected my husband's sperm sample into my body. You then have to wait 2 weeks to take a pregnancy test, and it was not successful. This was a huge emotional blow to me because I had thought, okay, we have unexplained infertility. Nothing is wrong with either of us. And so this should have worked, or I had thought it should have worked. I'd been symptom spotting and all of the things during that 2-week wait. We proceeded to do 3 more IUIs, all of which failed. At that point, we knew that our best chance of conception was through in vitro fertilization, or IVF, and so in July of 2018, we started the process for IVF. IVF happens in a couple of stages. So first, I went through the STIMS process, which stimulated my ovaries to produce additional eggs. This is 2 to 3 injections in the morning, 2 to 3 injections at night at home, and daily monitoring at the office, transvaginal ultrasounds every day, and blood work to monitor your hormone levels and your progress. Once you reach an ideal place of eggs on your ovaries and your hormone levels, they do what's called an egg retrieval, which is a sedated procedure. And then we were lucky enough to get 8 eggs. We were so lucky to get 16 eggs retrieved, which was much higher than I had anticipated. But of those 16, only 12 matured, and then only 8 were fertilized. So those 8 fertilized eggs had the chance to become embryos, and the lab watches them every day to see if they're growing the way that they need to. We were able to get 4 embryos total from our egg retrieval experience, and so we did a fresh embryo transfer, which meant that one of those embryos came right out of the petri dish and went right back into my body 5 days after it was created. That embryo transfer ultimately failed, and that was, again, really, really discouraging and really difficult to sit with, that, you know, essentially our first round of IVF had been a bust, and this embryo that we had created, that we had, you know, already started thinking about names for, this embryo was not a baby. It was not our baby. On the day that they did our fresh embryo transfer, they sent our other 3 embryos to the freezer, and we chose at that point to do something called pre-implantation genetic screening, or PGS, which looks at the chromosome normality of each of the embryos. Again, we were extremely lucky and blessed that the 3 embryos that we had frozen all came back as chromosomally normal. And we chose one of those embryos to then do a frozen embryo transfer, which happened in mid-September 2018. We were so lucky and so grateful that that embryo transfer was successful and grew into a healthy, strong baby girl who I delivered last May, in May of 2019, and she is now 15 months old. As someone with IBD, my pregnancy could have been considered normal, but between having IBD and going through IVF, I was considered slightly high risk, and I made the choice to work with a maternal fetal medicine team during my pregnancy and for my delivery rather than just an OBGYN. This is a completely personal choice, and there's not a right or wrong answer for this. The other big thing that was really important for my pregnancy and my health and my baby's health was my biologic use. So again, every person makes their own choices when it comes to biologic use in pregnancy and delivery and breastfeeding. As I mentioned, I take Remicade, and I felt like there was enough research available, and my physicians felt like there was enough research available, that it was advised that I stay on my medicine throughout my pregnancy, my delivery, and my postpartum period. I was getting Remicade every 6 weeks when I was pregnant, and I was actually due the day after an infusion was scheduled. And so the thought had been that I was planning to probably be induced a couple days early so I could deliver and then get my Remicade infusion in the hospital as soon as I had the baby. My baby had other plans, and my water broke at 35 weeks, 4 days pregnant, which was just about a week after I had had a Remicade infusion, and I had her the next day. And so my Remicade schedule actually didn't change at all, and I went and got another infusion when my daughter was 4 weeks old, right on schedule. I did choose to breastfeed. It was very difficult. Supply is an entirely different conversation on its own, milk supply, and whether it was because of my IBD or my Remicade or a million other reasons, I struggled with milk supply and making enough milk to feed my daughter, and my daughter struggled with latching onto my breast because she was premature and had a very small mouth. And so we triple fed for a couple of weeks, and I ended up choosing to exclusively pump, which meant that I pumped breast milk and she was fed out of a bottle. So I pumped for 6 months. I pumped during infusions at my infusion center. I pumped at home. I pumped in doctor's offices. I kind of did what I had to do. But I was really lucky and really blessed that I was able to provide breast milk for my daughter, and that my Crohn's disease and my Remicade use did not impact that. One thing that I do really want to mention is that my baby was considered immunocompromised for her first year of life because she was exposed to Remicade in utero. The only adjustment this meant for us, and we are a pro-vaccine family, is that she did not receive the rotavirus vaccine during her first year of life because it's a live vaccine. That was the only recommendation from my GI and my MFM team, and it was something that we spoke to our pediatrician about before I had the baby, and then again once she was here. That was the only adjustment that we made, and my daughter has been healthy, happy, and thriving ever since she was born. So that is a little bit about my pregnancy and delivery story. Well, actually, I guess I didn't fully talk about delivery. My water broke spontaneously, like I said, at 35 weeks, 4 days, and I was in labor, active labor, for about 12 hours. I had natural labor. I was very, very curious as to what labor felt like in comparison to Crohn's pains, and it's totally different. What they say about pressure is true. It's way more pressure than pain. But I was able to deliver my daughter vaginally. I pushed for about 2.5 hours. I did have some tearing, but I did not need an episiotomy. I did get stitches after delivery. But overall, I couldn't have asked for a better labor and delivery story. I thought it was super interesting when you guys responded to the questions that I put in the stories yesterday here on Galley's Instagram. About 70% of you said that you had thought about having a baby. A small percentage of you said that you had been trying to get pregnant or had gone through fertility treatment, and then about 20% of you said that you were already parents. And so it's great to know the audience that I'm speaking to, and if you're already a parent, you know a lot of this will sound familiar to you. I'm hoping that you can find something new or of interest in the messages that I share, and if you are thinking about having a baby or trying to get pregnant or going through fertility treatment, I hope that I can give you some advice and recommendations, and I hope that you'll also reach out to me with questions. So if you stuck with me this far, I really appreciate it. I felt like it was important to give you some background information about my story, which also hopefully highlighted some of your questions. So one of the questions I received was, who do you speak with first when it comes to talking about family planning? And as I mentioned, I started with my gastroenterologist, but I also spoke with my OB, and I chose to speak with a maternal fetal medicine specialist. IBD is a complex disease, and I always recommend that you have all of your providers involved in the conversation. I also have rheumatoid arthritis, and so my rheumatologist was part of my conversation as well on how pregnancy was going to impact my joints and any other supportive measures that I was going to need to take during that change in my body's time. The next question that I got was, should I be in remission before I try to get pregnant? And you know, the answer is, again, it's very subjective. I was told yes. You have the best chance of staying healthy and being healthy if you get pregnant once you're already in remission and not in a flare. However, that is to say that not every pregnancy timing is exactly planned. And if you get pregnant while you're in a flare, that's not to say that it's going to be a terrible experience. I just always recommend speaking to your provider, being in really close communication, talking about your symptoms, how you're feeling, what's impacting your health on a daily basis, what's impacting your ability to get nutrients and hydration, and how that would affect a developing baby. So ideally, yes, being in remission before you get pregnant is great. It gives you a great chance of staying healthy and through pregnancy. However, obviously, life is a spectrum, and if that doesn't happen, there are ways to do your best. There are ways to manage your health as closely as possible. Like I mentioned earlier, I was told that an ideal amount of remission would be 3 to 6 months before pregnancy, but I also know, again, that's not feasible for every case or every person. And so I really just advise you to speak with your healthcare providers and come up with a game plan that's going to be most ideal for your current situation. Another question that I get asked really frequently is, if I'm in remission, will getting pregnant risk my remission status? What's the risk of a flare during pregnancy or delivery? And unfortunately, there is not a straight answer on this. Being in remission before you get pregnant gives you the best chance of being healthy during pregnancy and delivery and growing a healthy baby. However, there's a lot of hormone shifts during pregnancy and delivery and postpartum. And as someone who basically my entire history with Crohn's disease, every single month when I get my period, I find that my IBD symptoms are impacted by the hormone changes. You know, pregnancy is not any different. And so the risk is there, absolutely. With Crohn's disease, just like other autoimmune diseases, the average law is about 1/3. So the law of thirds usually states that 1/3 of patients, their health stays the same during pregnancy, 1/3 of patients, their health gets better during pregnancy, and 1/3 of patients, their health gets worse during pregnancy. So speaking from personal experience, I was in remission when I got pregnant, and my Crohn's was the best it had been during my pregnancy. Now, that's not to say that I was healthy during pregnancy. I threw up every single day from the day I took a positive pregnancy test until the day after I delivered my daughter. Not common, not typical. Most people only experience that in the first trimester and then maybe towards the end of the third trimester. I was not diagnosed with hyperemesis. However, that's how my body chose to respond to pregnancy. I also carried a girl, and so it could have been my body's response to the estrogen. Regardless of that, I think it's really important to say that there is no way to predict how you'll feel during pregnancy or after delivery. And again, my biggest advice is to stay in constant and close communication with your GI and your primary care and your OB. Communication with your providers is key, especially when you're growing a human. While you have IBD, it's very, very important. And I think that really is going to be your best chance of success and of staying healthy, and also the mental flexibility that you kind of have to roll with the punches. And once you're pregnant, it's sort of the baby's responsibility. Another question that I got was the healthiest options for delivery for women with IBD, whether that's vaginal delivery or C-section delivery. And again, I know that this feels like the response I continue to give, but there's not a right answer. I can tell you, for me personally, based on my disease history, my goal was a vaginal delivery. So another question we got a few times is, can women with IBD conceive as easily as women without IBD? And generally the answer is yes, if you're in remission. Women who have active disease and are trying to conceive are more likely to have active disease during pregnancy, which can lead to pregnancy complications. Now, for a healthy, remissive state woman with IBD who is able to conceive and carry a baby, the health risks to the baby are minimal. A baby born to a mom with IBD may have a risk of being born early and may have a risk of being born small, but those things often depend on mom's nutrition, the ability for mom to absorb things during pregnancy, and the state of mom's Crohn's disease or ulcerative colitis. I do want to note that women who have had a colectomy or who have a J pouch may have a little bit different of fertility statistics than just a woman who has IBD. And these are really important things to talk to both your surgeon and your physician about before you begin trying to conceive. We had one question about a patient with an ileostomy asking if having an ileostomy or an ostomy of any kind can impact your ability to carry a baby. And from everything that we've seen, generally patients with ostomies do very well during pregnancy. Just like with anything else, this is something you'll want to talk to your provider about, but just because you have an ostomy does not mean that you should have more trouble getting pregnant or that being pregnant will be challenging for you. On that same note, we received a question about research on correlation between IBD and fertility issues. Great question. Always needing more research. What we know at this point, and the Crohn's and Colitis Foundation of America has a great fact sheet on pregnancy and complications and medication for IBD and fertility on their website. But what we know right now is, like I said, generally women with IBD who are in remission should have a very similar chance of conceiving as a healthy woman. Granted, previous medication, surgical history, all of those things come into effect, but there are many, many things that impact your fertility besides just your disease state, just IBD or not IBD. And so I don't want to make a general statement for all patients. And as a note, again, if you've had any sort of colorectal surgery, your fertility statistics may be a little bit different and it may be a little bit harder for you to conceive. And so these are really important things to talk to your provider about before you start trying to get pregnant. One of my favorite questions that we got is ways to stay healthy during and after pregnancy. I love this, and I think that it's also really hard. I can only speak personally about my experience with pregnancy, and my experience was that I was extremely nauseous during my whole pregnancy. I vomited every single day, and so what I was able to eat was not a well-balanced quality diet. Nutrition was challenging for me, and that was something that felt difficult. Exercise was challenging for me, and that was something that felt difficult. And so I think adaptability is really, really important in terms of staying healthy during pregnancy. Now, when you're talking about staying healthy from Crohn's disease or ulcerative colitis from your IBD, my personal recommendation is always, if you can, to stay on your medicine to keep your chances of remission as high as possible or staying in a remissive state. Now, it's important to note there are a couple of exceptions to that. Generally, steroids are considered low risk during pregnancy, but it's typically advised that women try to avoid being on steroids in the beginning of their pregnancy. So if you find out that you're pregnant and you're on steroids, this is really important to talk to your doctor about lowering the dose or tapering off. However, after the initial early phases of pregnancy, steroids are considered low risk. Now, when it comes to immunomodulators like azathioprine, Imuron, 6-MP, those also appear to be low risk. However, methotrexate is the outlier from that. Methotrexate is contraindicated for pregnancy, and so methotrexate should be stopped before you try to conceive. Now, when it comes to biologics, as I mentioned, I'm on Remicade and was on Remicade during my pregnancy. They're mostly considered low risk as well. However, some biologics do cross the placenta in higher levels towards the end of pregnancy, and some doctors may speak with you about pausing during your third trimester or changing your dosing schedule after you reach a certain point in pregnancy until the point of delivery. Now, in general, none of these medications should affect your fertility or your ability to get pregnant, but just like I always say, I think it's really good to talk to your provider or your care team about the medications that you're currently on before you start trying to conceive. We received several questions about biologics and breastfeeding, and I think this is a really great question too. Just like most medications for IBD are generally thought to be low risk with pregnancy, several of them are also safe for breastfeeding. This is also a personal choice, and it's up to you as a patient to do your research, to see what information is out there and to see what you're comfortable with. In addition to talking to providers, I always recommend that moms reach out to other IBD moms and have some conversations about what choices they made and why. And a great resource to this, I just want to shout out, is the IBD Moms group on Facebook run by Brooke and Amber. It's a super great place to ask questions like this and talk to other IBD moms who've been through the same pathway. As I mentioned, I did choose to provide breast milk to my daughter while I took Remicade, and this was okayed by my GI, my primary care, and my daughter's pediatrician. It was also a choice, and it was the right choice for my family, but I want to be very clear on that every choice is right if it's what's right for you and your family. So this is a really important one to think about your health, mental and physical, to think about your partner and your new baby, and to talk to your provider about in order to make the decision that's best for your family. One question that we got asked for questions to ask a provider, a potential OB, who's going to care for you during pregnancy, about IBD and pregnancy and delivery. Great question. Just like with finding your primary care physician and your gastroenterologist, I always recommend that your OB or your maternal fetal medicine physician, whomever is following you during pregnancy, is someone that you feel really comfortable with, talking about all of the challenges that you're having, from symptoms to fears and anxieties to hopes and plans. Much like you provide for appointments right now with your primary care physician or your gastroenterologist, you'll want to do the same thing when you're interviewing or preparing for appointments with your OB. You'll want to ask them how they're managing your health and your IBD symptoms, what the plan should be if you start to have IBD symptoms or a flare, what the plan should be if you need emergency IBD care during your pregnancy, who you should call, if your GI should be your first call, if they should be your first call, how they're going to monitor the growth of your baby, if your baby's going to have more constant monitoring than a baby whose parent does not have IBD, and also what things can you do, if any, to help prevent preterm labor and small birth weight for a baby, as those are usually the biggest concerns in an IBD pregnancy. And if your OB is not well versed in IBD pregnancy or the things that you're asking them, my suggestion would be to possibly find a different one, or to find another specialist that can complement your team, because it is really important to be able to have these conversations, and for your peace of mind and your family's peace of mind, that the doctor and the team that you're working with are well educated in IBD and pregnancy. I want to highlight another one of those survey results. So a big majority of people who responded were interested in learning more about female IBD and infertility or family planning. But there was a percentage of people who mentioned male fertility and family planning, and I didn't want all of my stories to be just geared towards females with IBD. So for males with IBD, there's a couple of things the ball's in your court with. One is medication use. So as I mentioned earlier, methotrexate is not advised for pregnancy. That's for a female or a male. So if methotrexate is what's currently managing your disease and you and your partner are talking about trying to get pregnant, you'll want to see if you can switch to a safer medication, one that is advised and recommended for childbirth. Now, another thing is, if you have IBD as a male and your partner does not, your partner is healthy, and you're struggling to conceive, I would recommend either seeing a urologist or asking your gastroenterologist if they can order a semen sample, if they can order a semen analysis. This will give you insight into the quality of your sperm, the number of sperm you have, the motility of your sperm, and if the sperm is causing challenges with your ability to conceive with your partner. If your sperm analysis is normal, that's great. That likely means that whatever is happening that's challenging you and your partner from getting pregnant is either a female issue or it's unexplained, and it most likely has nothing to do with your IBD. But you will want to speak with your provider, just like a female who's trying to get pregnant. You will want to speak with your provider before you start trying to conceive with your partner, on your health history, on your medications, and anything that you need to look for or avoid. There's also sometimes supplements that are recommended to support male fertility, and I would ask your doctor about these as well. Not just your primary care physician, but your GI, to make sure that they go along with your treatment plan and won't impact your IBD symptoms. Next, I want to address some sort of general questions that we received. So when it comes to supporting natural conception with IBD, my biggest recommendation is managing your health. So as I've talked about, being in remission for 3 to 6 months before you start trying to conceive is really going to give you the best shot at getting pregnant and being healthy during pregnancy and delivery. That means, in my opinion at least, managing your nutrition, your hydration, your medication, having a good support team in place, and really being intentional about your physical and mental health before you enter into a pregnancy. Obviously, there are supplements and things that can help from a general perspective when it comes to conception, but I think those should all be taken sort of with a grain of salt and should all be spoken with your provider about before you choose to use any of those. Now, when it comes to infertility treatment and IBD, it's sort of the same foundation. Good health for both partners makes this a lot easier and a lot more predictable. I mentioned when I talked about my own experiences, sort of starting with something called IUI or intrauterine insemination, and then utilizing IVF or in vitro fertilization. There are several other fertility procedures and treatments that are offered at different clinics, and the best bet for you would be to speak with a reproductive endocrinologist about something like that. So if you've been trying to get pregnant for 6 months or a year naturally and have not been successful, usually your OBGYN can refer you to a reproductive endocrinologist who can either start testing or make some recommendations on things that might improve your chances of success. Next, we received a couple of questions on surrogacy, which is a great question. I know that I thought about this too on my own journey to parenthood. And what I will say with surrogacy is that for a surrogate to carry your genetic child, you still have to go through essentially the IVF process minus the transfer at the end. So the female partner or the egg donor would need to be stimulated in order to produce follicles that mature into eggs. They'd be fertilized by sperm from a male partner or a donor, and then those embryos would grow and at some point would then be transferred into a uterus for pregnancy and hopefully delivery. And so that is the only part that you would not do. Another individual, your surrogate, would carry that embryo, but for the embryo to be genetically yours, you would still need to go through the process of stimulation and egg retrieval and then a sperm sample and fertilization. Well, I personally obviously did not go through surrogacy to have my daughter. I know that, again, I want to shout out the IBD Moms group, and I think it's a great way to connect to other IBD patients who've chosen surrogacy as an option. I know that offline I also have had clients utilize surrogacy to develop their families, and I'm happy to answer any additional questions that you may have about surrogacy. In that same vein, we received a couple of comments about individuals here on this platform with IBD who are starting fertility treatments or IVF, wanting to connect with other IBD patients going through fertility treatments. And again, I want to shout out to IBD Moms on Facebook. It's a great group run by 2 Galley ambassadors and IBD moms themselves, Brooke and Amber, and it's a great place to connect with anyone who has IBD and is trying to conceive or is a parent or is considering their options on becoming a parent. Circling back in Galley's DMs for today, one question I received from someone about one of my earlier stories was when my GI confirmed that I was in remission and that she was okay with my starting to try to plan a family and conceive. The question was that confirmed via colonoscopy? And the answer was no, it was not. My symptoms have always been a really good barometer of my disease activity, and it's something that we monitored closely. Once I had been feeling symptom-free for a long enough period of time, we made some decisions together. We did some lab work, and those things helped us make the decision that my IBD was well enough controlled that pregnancy should feel like a safe option. For my personal story, that was somewhat irrelevant because that was essentially almost 2 years before I actually ended up getting pregnant, based on trying to get pregnant on my own and then going through infertility treatment. However, my health only improved during that time. And if at any time during that period my health had declined, I would have paused my infertility treatments in order to get to a better remissive state first. And finally, I just wanted to say thank you and asking for questions surrounding the topics of IBD and family planning and IBD and fertility. A lot of you chose to share really personal parts of your story, and that means so much to me. I want to start by saying you're not alone, and I hope that my sharing my story and answering questions makes you understand and feel like you're not in this by yourself, and that there are other people who have walked this story, and that I believe in your hope and your happy ending as well. Some of you had really specific questions about your specific IBD journeys and how to manage a plan or create a plan in order to think about what parenthood may look like for you. And I want to be able to really answer those questions thoughtfully and also keep your anonymity. And so if you had a personal question or if you have questions based on anything I shared today that I did not answer, I'm including my own Instagram handle here. Please DM me. Message me with your questions and I will do my best to respond to every single one. I want to be able to have meaningful conversation in a way that doesn't feel rushed and it doesn't feel like I'm trying to fit it into a 60-second recorded video. So please don't hesitate to reach out to me. And that goes, like I said, with anything that you saw here today. If you have any additional questions or are looking for additional information, resources or support, or are wanting to work with an infertility doula like myself, please reach out to me at the link below.